All right, and welcome to Singularity University's Global Summit here with Daniel Kraft, the faculty chair for medicine at Singularity University and the founder of Exponential Medicine. Daniel, thanks for being with us today.
Good to be here.
So, Exponential Medicine, what is it? How do you define it?
What is exponential medicine? So I'm a physician, trained in traditional, Stanford, Harvard residency, fellowships. A lot of medicine, we like to think it's evolving, but often feels quite incremental. And Exponential Medicine is a program I founded out of Singularity University in 2011 that looks at all these fast-moving technologies from AI, robotics, digital, mobile, cheap genomics, to chatbots, to drones, and beyond, and how they are coming together and converging to enable us to rethink and reimagine how we might practice health and medicine across the healthcare paradigm, from health and wellness and longevity to a better job of doing early, low-cost diagnostics to more personalized, more precise therapy, to clinical trials, global health, etc. So it's a program we run every fall at the Hotel Del Coronado. The website's exponentialmedicine.com, and you can watch lots of great talks there from amazing world-class faculty, where we spent 4 days diving into what's the cutting edge, where's the puck going, how do we learn from others and connect the dots with some of these new tools and technologies so that can get us out of the fax machine era, which we have today in medicine, or sort of, I call it sick care, reactive model, where we get little snippets of data from ourselves or our patients and end up reactive, waiting for folks to show up in the emergency room with a heart attack, a stroke, or advanced cancer.
Interesting. So predictive medicine. That's
predictive, not addictive.
Yeah, predictive. Well, speaking of addictive, we actually just came out the big section on the opioid crisis right now. So where in the continuum of care are there different solutions? Pre-exposure, exposure, withdrawal symptoms, everything in between. Is there any certain medicines that you're excited about to combat addiction? And what does that look like right now?
I think the opioid epidemic is a complex issue, and it has a lot of different etiologies, but one of them aligns with how we incentivize behaviors for physicians and patients. And about 15 years ago, there was this new idea that we need to treat pain as the fifth vital sign, and that to start judging, measuring, and rewarding hospitals and physicians for doing a better job of pain management. Of course, you don't want a patient to be in pain, but now we were measuring and incentivizing to give more pain pills than maybe someone actually needed. Maybe I'll give you 2 bottles instead of 1, so you get a better pain rating.
Yeah.
And that helped kick off the opioid epidemic. You'd have extra bottle, the patient would take extra, the kid might steal them himself on the street, and that was part of the etiology of the opioid epidemic. Other elements are now some insurance companies like Optum can look at the data of how physicians are prescribing. Sometimes too many pills than should be there, or too many refills. So there's lots of ways to look at the underlying etiology and ways to abrogate more pain pills being out there than should be. And then there are technologies now to maybe help reverse it if someone is addicted, from an app for mindfulness training all the way to connected pill bottles, which will only let you take a pill at a time, all the way to new drugs and other approaches which can not just treat the patient but give a layer for the family and the caregivers. We're all impacted by folks who might be addicted.
Integrative medicine, I think it's a new. I mean, it's not really new. It's been around for a long time, but now it's kind of coming to the surface with conversations like Dr. Weil, and we spoke with Dr. Charlotte Mordier, who's double board certified in integrative medicine and addiction interviewing, actually, I think it was. And it's very interesting. What are some of the discussions that you've been having with some of your colleagues about integrative medicine and its approach?
Integrative medicine should be all of medicine. I mean, really, we have now in this era, I'm specialized in hematology oncology. I can already have blood cells or cancer. And then here in San Francisco, you might have a specialist who does right hand and the other left hand. And we really want to treat patients as holistic entities, physically, mentally, in society. But now we're entering this big data era of omics. The fact that I can get your genome for now less than $600, your microbiome, your proteome, your blood chemistries, your digital exhaust from your mobile watch or connected Internet of Things home. And that portends really a true era of integrative medicine. We can start to connect the dots between your different omics, your proteome, all the omics, are too much data to make sense of. But now we can hopefully integrate them so that if we're looking at your inflammatory bowel disease, we can look at your microbiome, or how the inflammatory markers in your blood relate to your diet, or ways that your underlying genomics might play a role. Or look at your symptoms that might be collected on your mobile device and connect that to your physiology. So bottom line, in this exponential age, we can now start to collect massive amounts of data, hopefully integrate it with the help of machine learning and AI, so that no physician wants to look at every piece of data from you every time you went to the restroom, every time you had a burble on your EKG, but now to synthesize that in an integrated way to hopefully be proactive and give you personalized prevention if you might have a risk for a disease, to help diagnose something early if you have it instead of late, and then if you have a disease, whether it's hypertension or inflammatory bowel disease, to treat it in a much more data-rich, connected way. So that's, I think, where I think about integrated medicine, which traditionally can be a bit almost crystal woo-woo,
Sure.
Now is entering this era of systems medicine, systems biology, where the near future is each of us will have our own sort of digital avatar of ourselves, our digital twin. And I'll look at you and I'll be able to even test a therapy on your sort of calculated response, knowing your pharmacogenomics, what statin might work best for you, or if you're going to be doing exercise or trying to lose weight, how do we look at your microbiome, your genome, your blood sugar values in real time, and then predict, not the same one-size-fits-all diet that might be given to every other person.
Interesting. What's a technology or a solution out there that you've heard of that might be hard or difficult for our viewers at home to conceptualize?
Well, some things are a little easier to conceptualize. We can take it to the next level. So on my Apple Watch now, I've got the Apple Watch EKG, or the AliveCore device that's on my phone or watch as well, that now can do a basic 2-lead EKG and tell me my atrial fibrillation, which is a common form of an arrhythmia, and now can also, with machine learning, pick up is my potassium high or low. There's a new version of the device, which I pull out of my pocket, it's my bag, which can enable you to do a 6-lead EKG, something you normally have to go into the clinic for. So now we can start to collect something as pretty integral as an EKG anytime, anywhere, and now apply machine learning to extract other data from your EKG. Are you looking like you're having early signs of a heart attack or at risk for one? Do you have a certain type of funny heart rhythm? And now be able to monitor you, not just in the clinic, but potentially 24/7 at very low cost. And so it's the advent of now, digital diagnostics being brought to your pocket. Across the room there's the X Prize. I helped come up with the Medical Tricorder X Prize, which was a prize that was won a couple years ago to start building home-based diagnostics that can be in your pocket, that can do as good a job as a common physician in diagnosing the 16 most common issues that people have at home, and triage them. So we're seeing the advent now of ways to do clinical-grade, FDA-approved diagnostics, from an EKG to using your voice as a biomarker, to tracking not just your steps and sleep in high detail, but lots of other information that we're going to hopefully use to empower us as individuals, as consumers, as patients, and then us clinicians can hopefully have a dashboard of your data, not just the data, but the actual information, how it's been integrated, so we can use that proactively to keep you healthy, or if you have a problem, to manage that disease.
It's an interesting conversation, because I think our healthcare system soon enough will be flipped on its head. There's a lot of problems with it, and so many solutions are coming up in this day and age. But when you're speaking about pre-exposure and pre-diagnosing things, getting ahead of the curve.
I call it stage 0 medicine. You want to pick up stage 0 cancer and treat it at its very early stage, or stage 0 Alzheimer's. There's now several blood-based tests, eye tracking software, pictures of the back of your retina that may predict who's likely to get Alzheimer's 10 or 20 years early. So you can pick them up before they have symptoms, and maybe start with some drugs that might stop and reverse plaques. Or even there's a new biotech company in the Bay Area that can treat some of the bacteria in your mouth, the microbiome of the mouth, that has an enzyme that seems to catalyze plaques in your brain. So very interesting approaches, just like you might take a statin if you have a high cholesterol or a heart disease risk, treating disease before you end up having the acute event, whether that's a heart attack or clinical grade dementia. And in terms of flipping the healthcare system on its head, it's really a sick care system, based on intermittent data, reactive model. The near future will be continuous. Information flowing from your Apple Watch, your connected home, will give you your own sort of check engine light that will give you early warning before you crash your car, crash your body. And our data can be crowdsourced, just like we have driving maps crowdsourced to build a better and what's ways for healthcare, where we're hopefully all donating some data in a safe, privacy, and secure way, but we get a better map for our own healthcare journeys, whether that's for precision wellness or to manage a chronic condition.
Does this technology discriminate against people in different income levels?
Well, I think my hope is these things, almost everyone has a smartphone, and those have gotten exponentially cheaper and more powerful. It's going to democratize healthcare. We're seeing in China, where there's not a lot of physicians in rural China, this app called Good Doctor that over 200 million Chinese are already using. We can imagine now everyone's going to have a Siri, a Dr. Siri version, whether it's from Apple or Amazon or Facebook, that can be used for triage. You have no clue what's going on. You ask Dr. Siri, I've got abdominal pain. What's going on? Well, Siri will know if you're a pregnant woman, if you're a 60-year-old guy who's already had his appendix out, what your genomics are. So it can answer in context based on you, not just the random average questioner. So I think these things can democratize access to information and then even care, which increasingly can be appified. Sometimes it can be an app for meditation that can help treat depression or anxiety instead of a pill. It might be platforms to help connect patients so that they have social connection, that's just really important for many medical groups. So bottom line, I think technologies will democratize access to diagnostics and therapy and public health. There's a lot of health is driven by our social determinants, how connected we are. Do we have access to clean water and food, not fancy gene therapies?
Gene therapy. Doc, you were mentioning genomics earlier. How close are we to gene editing?
Well, it's here now. CRISPR is a technology. CRISPR technology for spot editing specific parts of the genome has been out only for about 7-8 years. It's moved very rapidly into the clinic, and as of this month, July, August of 2019, some of the first CRISPR-based trials are rolling out in the United States to treat some very classic diseases like sickle cell disease, which is a single base pair anomaly in the bone marrow stem cells of sickle cell patients, which leads them to having some of their red cells sickle, causes pain, causes clots, early death in many cases. And now we can take out some of the bone marrow stem cells from these patients, fix that single gene, retransplant them, and those are in clinical trials now. Also for diseases like thalassemia, another blood-borne disorder, or for some certain types of blindness where there's a single gene where we can learn to modify the gene back to the normal phenotype and hopefully lead to long-term cure early before the disease has had its big manifestations.
Can you break it down just on layman's terms to our audience what gene editing is? I feel like we might have skipped over that.
So most folks know about DNA. DNA encodes our proteins. Our proteins help build red cells, tissues, and beyond. So in the case of your blood system, there are blood stem cells in your bone marrow that make red cells, white cells, and platelets. And in the cells, all of our cells, a patient with sickle cell disease, there's a single base pair, there's AC or T and G, where it has an abnormality, meaning when the red cells are made, the hemoglobin, the red part of your red cells, they fold a bit differently and causes the red cell, the sickle, turn into a funny shape that often gets stuck in your spleen or in other organs and cause pain and infarctions. And so, since that's a very classic genomic disease with a single gene that we can identify, also genes like other diseases like sickle cell disease are often a single base pair anomaly. We have a potential to fix that one gene with a single targeted gene editing, which is now being done with CRISPR and some other approaches, that if you can fix that gene, will prevent the whole downstream cascade that will become sickle cell disease.
And when I think of gene editing or even stem cell, what are some of the regulations or ethical conversations you're having with other people, and what's your stance on that?
Well, it's one thing to edit cells in basically adult tissue, like your blood forming stem cells. Another thing to start editing the genes of a baby or at the embryonic stem cell stage, or in your sperm or in a woman's egg.
Sure.
And what had happened earlier this year, the report out of China, the first CRISPR baby was made where arguably very unethically, without actual IRB, meaning ethics and guidance, this Dr. He went forward and edited embryos of a couple, knocking in a gene that would hopefully, theoretically, prevent those children from having higher risk of HIV infection. So it's a bit of a long, crazy story. I won't encapsulate it here, but it's a slippery slope of trying to modify embryos. And you might want to modify to prevent a disease, like knock out the sickle cell gene if you know you have that. But what happens when we start knocking in genes for blue eyes and blonde hair or higher intelligence related genes? Or when you can start having a library and start selecting, basically hacking Darwin, basically being able to accelerate evolution. You might have the genetic haves and have-nots. Some of your viewers may have seen the 20-year-old movie called Gattaca, which Ethan Hawke is the child born without genetic modification. He's then discriminated against because everybody else is getting genetically modified. He doesn't get to be an astronaut and he hacks the whole system. But that's not so far off. We can start to sequence everyone in this room now for less than $1,000. We might discriminate you if I'm going to hire you and you've got higher risk for heart disease or cancer. Am I going to hire you?
No.
There's rules about genetic non-discrimination, but no reason you can get a bunch of genetic 10s together, do your own self-insurance plan at a lower rate. Or if someone's running for president and we took Donald Trump's glass he drank from and sequenced him and published his risk for dementia, which some argue he already has, or other neurologic or psychiatric disorders, what would that implications be for privacy there? So that brave new world's coming, and the challenge for the regulators and the folks who think about ethics and policy, it's often outpacing the policy and the ethics and the regulatory process.
Well, Doc, I hope by the time I have kids, I can get your brains for them. Appreciate your time here on the Real Ears Live. Folks, Dr. Daniel Kraft of Singularity University, faculty chair of medicine here at Singularity University, and the founder of Exponential Medicine. I appreciate your time.
And encourage your folks to come check out exponentialmedicine.com. You can join us this November 4th through 7th at the Hotel Del Coronado in San Diego, and we spent 4 days diving into everything from CRISPR babies to chatbots to drones that deliver drugs and vaccines to psilocybin for treating PTSD, the whole spectrum of where healthcare can be reimagined through the lens of advancing technologies.
Wonderful. You heard it here first. Doc, appreciate your time.
Thanks.